Well, hi and welcome, Sarah Gavin. Thank you for joining me to discuss how CommuniCare is transitioning to virtual visits in this new environment. I just wanted to give a little bit of background for folks joining us on this webcast. CPCA has fielded several questions about just what a virtual visit looks like and how it differs from an in-person visit. So we wanted to invite one of your colleagues who has graciously agreed to walk us through a demonstration visit and answer a couple of questions. I wanted to introduce you, Sarah, to our audience. Everyone, this is Sarah Gavin. She is the Chief Behavioral Health Officer at CommuniCare Health Centers, which has several locations located throughout Yolo County. CommuniCare has always been deeply invested in behavioral health access and quality. You offer a full range of behavioral health services from specialty mental health, individual and group visits, substance use disorder services, integrated behavioral health, case management, the whole gamut. And so we've presented a few times together in the past, and what I remember hearing from you is that CommuniCare's behavioral health department is actually a third of the whole CommuniCare budget, and you have up to like 100 staff members now. Is that correct?
Over, yeah.
Yeah, that's exceptional. So we really appreciate you're always willing and open to share, and we really appreciate you coming on this webcast today. Is there anything else that you want to say about CommuniCare's behavioral health department before we get started?
I actually just wanted to express my appreciation for health centers across the nation. We have been models in flexibility and treating the most vulnerable in very unique adapting circumstances, and I think this has been an opportunity for health centers to shine, and it's been incredible seeing the work and the pivoting that people have done really quickly.
Yeah, it really is. I'm constantly impressed, and I love just touting to all of my colleagues both in the state and other state associations and nationally just how amazing California's community health centers are. You guys are really doing some incredible work in providing access to the most vulnerable and ensuring that their quality of care is top-notch. So thank you very much.
Yeah.
One thing before we get into the Q&A section of this presentation, and then we'll go and do a demo visit, and then we'll wrap up with a couple of follow-up questions. One thing I just wanted to know is just kind of how you've found the transition to virtual visits to be at CommuniCare. What's been surprising? What's been exceptionally challenging for you? Just give us some insight there.
Yeah, well, it's interesting because normally if we were implementing something like telehealth, there would be, months of planning and policy development and training, and of course this happened, I think within 24 hours of us getting notice that we're going to need to move to telehealth. So it's been an exercise in quick thinking and flexibility, certainly. And so our team has been just incredible in adapting and recognizing the need for this. And, we have, like you said, over 100 people working in behavioral health. None of us had done telehealth before, and certainly done, in grad school and research and things, that, we were hoping that policies changed so that we're able to do it. And so then all of a sudden it just opened up very, very quickly. So I want to actually first start with the good things and then some of the challenging things. So, many of us in behavioral health have wanted to do telehealth visits for a long time, right? We see the need. There's barriers to care for transportation, for people with tremendous anxiety or history and trauma, and being able to just sort of call or engage in a therapist and not come into a health center is something of value for a lot of people. So we had some therapists that were really excited and said, actually, I have some patients that would love this. And we've seen some engagement with some of our patients and clients that we hadn't seen before, where people weren't attending. And, in this time, people are really valuing helpers, wanting to support them and connect with them, and people need it right now. So that's, and of course, you referenced access. So, we don't have to think about where the provider is or where the client is, right? It can be, so there's an adjustment to access, and people are able to see more people and able to reach, clients that weren't able to come otherwise. So I think that's positive, and I've heard really that positive feedback. Some of the challenges has really been actually in our substance use treatment programs, where you can imagine the best practice in substance use treatment is peer group support. And so we relied heavily on groups where people came up, came and showed up and supported each other, and we have dozens of groups that run a week in substance use treatment, and UA testing that we provide as a tool to part of, and so all of that obviously has changed. So that's been the biggest transition, actually, is how do you take best practice in substance use treatment, which is really group support, and then transition that to telehealth. And so that happened first with individual telephone visits, then to individual group video visits, and then to group video visits, which we just launched within this last week. So now we're doing group video peer support visits in substance use treatment. So that was a huge transition for those clients that were relying on daily group support. There's technological challenges with clients that don't have access to data on their phone or have internet that's not great. Of course, we're asking clients to have a confidential space, and, when you're living in a studio apartment, that's difficult, right? And so then when you go outside, then you can't get on the internet. So there's all those kind of technological challenges that are frustrating to both the clinician and the client. So the transition it's been iterative. Like, there's been things that we started that feel really good, and then we kind of have to change and pivot, and it's come with some really great opportunities and some challenges.
I'm curious to know who's on your virtual care team and what are their roles and their responsibilities, and perhaps if you could frame it in terms of who was there before and who's there now, that would be really helpful for folks to know just how you're moving staff around, if you are, and just exactly what they're working on.
Sure. Yeah, I do want to preface this by saying that we provide a vast array of services. So we have specialty mental health for kids, adult specialty mental health, integrated behavioral health, substance use treatment, medication-assisted treatment services. So every care team within that program kind of functions a little differently, and then psychiatry and adult and child psychiatry. And so generally speaking, we have our front desk staff in every program and the clinician, and then some programs have MA support that is part of that care team. And of course, in medication-assisted treatment, we have nurse case management and that piece of it. A lot of I would say the biggest change in this is that there's conversations that have to happen between the client and the clinician really to orient them in this process, that we can't be as reliant on the front desk to just set up the visit, right? Because we really have to explain and walk through the process and troubleshoot some of the technology and consent piece of it. And because we had to implement so quickly, we weren't, implementing electronic signing or consent, to the client just yet. And so the front desk definitely sets up the appointment. They ask them if, they're able to have a telehealth appointment. Are they able to have a phone call they received, or do they have to come in? We are still doing some in-person services for clients that need to, for a variety of reasons. Some people don't have access to a telephone, or their mental health or social situation prohibits them from really being able to engage in that way, and so we have them come in. And then really the therapist or the clinician, or depending on the team, the case manager will call and sort of talk through some of the options before the first visit in order to set up what would be the next step in that visit. So it looks a little bit differently.
Yeah, that's what I was wondering about, is who's kind of orienting the patient to this new virtual visit, and it sounds like some of your case managers and some of the support staff are doing that.
Yeah, and I would say the majority of those conversations, especially the orientation of ongoing clients, was really through the therapist. Because you can imagine, as we all were processing this huge change in lifestyle, right, and sheltering in place, and that our clients are, dealing with that too, and so it's confusing. Like, will I be able to go back to my health center? Will I be able to see my therapist? Is he or she going to actually come in the office? Are they staying at home? And so it really, it takes a little bit of extra care. And so we felt like it was really important to have the therapist have those conversations and explain, like, we're still going to have our same visit. It's just going to look this way. And these are the options. And that's more of a trauma-informed intervention anyway, rather than have someone that they don't have a rapport with call and say, here's the link to your visit. It's confusing, and we really were concerned about disengagement with this process. We were really concerned that people were just going to say, okay, well, I'll come back when this all settles down. And we really didn't want that to happen. We really wanted to have some continuity, especially because there's so much stress and uncertainty. Behavioral health is really more important, very important in this process.
Yeah, absolutely. In a supervisory role, are you checking in with your staff? Are you you know, emailing them or having one-on-ones or anything like that?
Yes, so every team has a weekly staff meeting, and we have changed that all to be virtual. And so that helps too, because we can actually see the space that employees are working in, right? Like you can see them and practice it a little bit and see the setup and that piece of it. And then of course supervisors are really increasing their time, their individual time that they're having with their employees, and we're doing that all over video so that we can practice it and see what's happening and be able to support, you know, and also to be able to see our employees and how they're doing. I mean, we just had our first sort of virtual behavioral health all staff meeting, so it was like 90 plus people that came, and it was amazing. I was like, oh my gosh, I miss you guys. Like to see their faces, it's just a different experience, and everyone's working in kind of an isolated way now, and behavioral health people go into the field because they like connecting and being with people in the same room. You know, they're social people, and you know, and so much of the work that we're trained as therapists is to rely on sort of what's happening in the moment with nonverbal cues and what's happening in between, you know, between you and another person. And it's very difficult. There's like a 1 second delay on video. You can't really read so much of the, you know, someone was telling me a funny story where they thought their client was upset, but it turned out that they were frozen. And so they were, you know, it's just that kind of, it's like this, you know, just trying to figure out this new normal and how people are taking care of themselves, and recognizing that our employees are managing their own transition. They're having kids that are no longer in school, or they're not being able to rely on the same, you know, village of support that they were able to before. They're worried about the health of their partners or family, and so they're dealing with all of that while working, you know, full-time and managing this. So we're doing our best to increase some of that support for them so they feel that.
And then the other question that I have before we get into this demo visit is just really wondering how you're creating, like I mentioned earlier, CommuniCare has been really innovative and on the forefront of behavioral health and primary care integration. And so I'm curious how you're maintaining that connection between primary care and behavioral health, both in like the case conferencing space, but also in the, you know, urgent, warm handoffs. Just what that kind of looks like.
Yeah, so this was actually one of our biggest concerns, was the integrated behavioral health program in this and having them off-site. And so we do have some in-person integrated behavioral health services still happening, and we have really been promoting that if there's a crisis in the moment, to please notify behavioral health and we'll send someone in person. We still feel like that's really important, especially, you know, with depression and sort of the increased stress. We've done it in a variety of ways. We have provided it in person, you know, with protective, you know, equipment and, you know, social distancing. We've also provided it actually next door, where we've done a warm handoff and then sat a client down at a computer and then, or a phone, and called them and talked to them, and we were next door or down the hall or at home. We've set up the process that I alluded to earlier around that if you call a clinician's extension, it rings on their computer. So our integrated behavioral health clinicians know that there's still, you know, we want to promote warm handoffs, and they're still going to be doing those virtually. And so it's happened where they've called and picked up the phone, and most of it has been through telephone. And then we are in the middle of a move and with one of our sites, and so we're looking at actually ordering tablets where the primary care clinician could bring in a tablet and have a consultation with the IBH clinician kind of in the room, rather than having to like move the client, or, you know, or kind of the sort of clunky setup that can happen. And so that's kind of the next thing that we want to pilot, so it's a little bit easier, so we can have a little behavioral health clinician head on a tablet talking to the client. And that sort of thing. Yeah, and then of course for like non-urgent issues, we're just still, you know, referring to behavioral health and making an appointment, and, you know, then we'll call them and orient them to what that would look like and how we'll do it and that sort of thing.
Cool. Cool. Thanks. Well, I think now is a really good time for us to move into a demo visit. So as I understand it, you have worked with one of your colleagues to walk through what a visit looks like from kind of start to finish, and looking at what the consent process looks like, looking at what some screenings look like, all done virtually, and then how to handle any crisis situations that may come up during a visit, and all the way through the process of saying goodbye to the patient, what the follow-up plan looks like, and then documenting that. So we're going to transition to that short little video clip, and then we'll come back and I have a few follow-up questions for you.
Yeah, great.
Hi, Sarah.
Hi.
So I'm really glad you were able to make it today to this telehealth visit. During these times, I think it's really important that we're able to stay connected and continue with services. So what we've done is we've moved to, because of social distancing requirements, we've moved to, and the spread of COVID-19, we've moved to doing services in this way, providing services via video. And so in order to do that safely, there are some things we need to review today. Will that be okay?
Yes.
Yeah. Okay. So the first thing I need to know, and I'll explain a little bit more about this later, is your location right now. Can you tell me your current address, and so I know where you're at physically?
Yeah, I'm at home. So it's the address that you have on file,
Okay.
10940. Maybe.
Okay. Okay, great. And then I also want to offer you, normally we're in my office and my license is on the wall, but I want to offer you my license as a marriage and family therapist and my licensure number. So I want to just give you that information.
Okay.
So for us to proceed, I think telehealth, again, is a way for us to continue with services, and I think there are some really great things about it, and there are also some risks. So I think before we proceed today, I need to read through a consent and make sure that you and I are on the same page about what those risks are and also what the benefits are.
Okay.
While I'm reading through the consent, if there's anything you don't understand, please feel free to interrupt me, and I'll stop occasionally and check in and just make sure that you're following and that you're understanding what I'm reading.
Okay.
Okay. If we get disconnected at all, what I'd like to do, because technology is never predictable, can I call you? Do you have your phone near you?
I do, yeah.
Okay. Okay, so if we get disconnected, let's try to connect my phone and I will call you.
Okay.
And I'll troubleshoot and figure out how to get back online.
Okay, great.
Okay, so I'm going to start reading the consent, and again, please pause me if you have any questions. So afterwards, I'm going to ask for your approval. So it starts by just saying, I, Sarah, hereby consent. Okay, so that's the consenting process.
So that would be typically like a first visit, right?
That's the very first visit, yeah.
The very first visit, and if health centers were set up to do like DocuSign, that's something that would be sent to the client for them to review on paper and electronically sign.
Exactly, that's ideal.
Well, it's not there yet, so we have to verbally review it and proceed.
We have had some clients where we've been able to email the blank form to them in an encrypted fashion, and so at least they can review it and see it and read it, and that expedites the process a bit. Yeah.
And then so if this were a follow-up meeting, not the first meeting, what would the consent look like for that?
So if I am calling back on the second visit, what I would say is, today we're going to be conducting our session via telehealth again, and the reason we're doing this is because we're trying to reduce the chances of spreading the coronavirus and honor the social distancing requirements. Just going to remind you that, because we're using this forum, I cannot 100% guarantee the confidentiality of our communication. And sometimes there are also things that I can't fully assess on the phone, things that are going on with you. So you have the right to end this visit at any time and let me know if there's something going on with you and an emergency situation at all, so that I can respond to that. And before we start our session, I'd want to ensure that you understand this isn't a secure connection. And I also want to be able to confirm with you your current address. Again, I know we asked that last time, but can I just confirm that you're at home and at the address we have on file for you?
Yes, yeah.
And I can offer you my licensure name and status again. Again, I'm a marriage and family therapist, and my licensure number is
Thank you.
for your reference, yeah. The other things that I would touch on following the consenting process is to talk a bit about the logistics. So, you know, preparing the client. Clearly, they're on the call here already, but and so some of that's already happened. But making sure that they understand that it's important to maybe even log on a few minutes early to make sure that we have a secure connection as best we can and work out the technical kinks before we start the session. So Sarah, I'd like to do a PHQ-9 screen with you, if that's okay. I think we did one when you came into services at the beginning, and this just helps us kind of check and see how we're doing. It's one measure for us. So your answers, the screen is just going to be over the course of the last 2 weeks. So today is the 6th. You know, we're looking at about, you know, the last week in April, essentially, until now. And your answers are going to be not at all, so 0 days out of the 14. Several days, which I would consider maybe 3 or 4. More than half, so 7 or more, or nearly every day, so all 14 days. And ask me if you need a reminder about that. I'll remind you. So in the last 2 weeks, have you experienced little interest or pleasure in doing things that, you know, that you used to enjoy? So not at all, several days, half, or nearly
several days, maybe.
Okay, thank you. And in the last 2 weeks, have you been feeling down, depressed, or hopeless in any way?
Yeah, some of the days.
So several days again?
Okay.
Have you had any trouble falling asleep or staying asleep or sleeping too much?
No, I would say not at all.
Not at all, okay. Have you been feeling tired or having a little energy?
Yes, I would say several days.
Okay. Poor appetite or overeating at all?
No, none of the days. No.
Have you at any time been feeling bad about yourself? You know, having thoughts that you're a failure, have let yourself or let your family down in some way?
No.
Okay.
No days.
Okay. And have you been having trouble concentrating on things like, you know, simple things like reading a newspaper, watching television?
Yeah, I
Okay.
think so.
How many days do you think over the last 2 weeks that's happened?
I would say several days.
Okay.
Most of the days. Yeah.
Several days or most of the days? I'm sorry, I missed that.
I would say most of the days.
Okay, thank you. And then this next one's, have you been moving or speaking so slowly that someone would notice? Or the opposite, sort of being really fidgety and moving around a lot more than usual, and someone would notice that too?
No days.
Okay. So then this last one is, I'm wondering if you had any thoughts that you would be better off dead or hurting yourself in some way?
No.
No. Okay. Thank you. We're done with that. So that'll help me just track our progress as we work together.
Okay.
Any questions about that at all?
No. Just being inside a lot is just contributing to a lot of those things I don't normally experience.
Yeah. I imagine that's true for a lot of people right now. So, yeah. So Sarah, part of us working together remotely is that I need to, I know earlier I asked you for your address, but I need to be clear about where you are. And part of that is that if any safety concerns arise, either for you or someone else in the household, I need to know where you are in case I or someone else need to respond. So I kind of just wanted to talk through what the response would be, just so it's not a surprise if it ever has to happen.
Sure.
So if something like that were to come up, I think the most important thing is that we stay connected, is that if we can, that we stay on the line so we can talk through it and make sure that I get the help to you that you need and support you through it. If for some reason we were to become disconnected, I just want you to know that's when I would follow up on the emergency contacts that you've given me. And depending on what the situation was, reach out to, I think you gave me your husband's number, but reach out to him so that he could, check and see how things are. If for some reason I wasn't able to reach you and I wasn't able to reach him, and I was really concerned about you or someone else there, then I want you to know that the next step for me would be to call a community safety officer and have them come do a check at the home. So,
Okay.
so that's the protocol, and I think as long as we can kind of stay connected through whatever comes up, that's ideal.
Okay.
Yeah.
Okay. Thank you.
Any questions about that at all?
No, I mean, I don't think that will be necessary, but it's good to hear the options and what would happen. Yeah.
Okay. All right. So now that we're done with the consenting, I just really want to know how you're doing with all of this, the pandemic and social distancing, and how this has been for you. Another thing I might do is do a scaling question. I might ask just to sort of measure stress levels, understand, on a scale from 0 to 10, I'm curious how, agitating, stressful this current social distancing and COVID response has been for you.
10 being like really bad and 1 being...
Yeah, exactly. So 0, I would say 0 to 10. So 0 being, you're happy to be at home and happy to be on your own. There's no distress, and 10 being that, yeah, it's very, very distressing.
Yeah, an 8.
Okay. Mm. Yeah. Okay. Well, I think we should talk about that for sure. I'd like to understand what's coming up for you. So Sarah, it's time for us to wrap up our session for today, and I'd really love to know how this was for you over video in a few words, if you could kind of share with me.
Yeah, I mean, at first I thought it was going to be really awkward, but actually talking to you, I mean, within a few minutes I sort of forgot, we're on video, and I feel like I'm feeling a little bit more comfortable with the way we proceed. So I appreciate being able to talk to you.
Thank you. Well, I'm really happy to hear that. Okay. And, I'm curious in terms of your goals coming into the session today on a scale from 1 to 10, with 10 being your goals were absolutely met today, if you can give me an idea of how the session was for you.
Yeah, I would say a 9. I mean, I always wish we had more time, but yeah, I would say a 9.
Okay.
Good.
Thank you. Okay, that's helpful. I really appreciate that feedback. So, so next week we're going to meet back at the same Doxy address, and I will be on about 5 minutes early in case there's any technical issues. And what I will do, if you're having trouble, just call me, and then when our time starts, I'll invite you from the waiting room. So I think when you log on to Doxy, it puts you in a waiting room, and then I'll start our session right on the hour at 3.
Okay, great.
Yeah. Any questions about the logistics at all?
No, I was able to log on okay today, and if for some reason the internet's not working, the kids are on the internet, you'll just call me.
Yeah, I'll give you a call if we can connect. So.
All right.
Okay. Have a great day.
Thanks. You too.
Yeah, so this is a typical note for our televisits, and what we're going to document is some language about due to the current pandemic, services are temporarily being delivered via teletherapy, and that we obtained a verbal consent from the client using the script that I used. I mentioned how the session was delivered, and today we were on GoToMeeting. I mentioned that I was able to identify the client's identity. If I was not on a go-to-meeting and couldn't see my client, I would, and I was just on the phone, for example, I would ask some identifying information like their date of birth. We did confirm that she's at her home address here in West Sacramento, and I do completely fill in that address into my note as a confirmation, and that I offered the client my BBS registration title and registration number. And then through the course of our time together, you know, you're constantly assessing, but I want to make a note that I assessed that this client today was appropriate for telehealth. And if she had not been, then I would have made arrangements for her to come into the clinic. So that is all documented there under consent. And then we have another place that we are documenting really for data purposes to track how many of our sessions we're able to conduct via video and how many of our sessions that video is not an option, so that we're using just the phone. So that gets indicated. And then embedded in all of our templates during this time is the information listed here as a result of Assembly Bill 1494, Declaration of a State of Emergency, and Governor Newsom's statewide order to shelter in place. CommuniCare will provide telephone or telehealth visits when appropriate. So that is, and then we would complete the note as always with notes about the session content and the client's response to treatment.
Thank you so much for taking the time to demo that visit. Really appreciate it, Sarah.
Yeah.
So I just wanted to ask a couple of follow-up questions now that we know what the process looks like. I'm curious to know if any of the process that you just demoed for us, if that changes when it's a telephone visit versus a video visit. Does it look any different?
It looks pretty similar. With video visits, we're of course stressing confidentiality and space a bit more because obviously, you know, there's a visual component, especially with group video visits. As you can imagine, there's other people's confidentiality that we need to think about. And then the flow of just technology and then setting up a link. But in terms of consent and our process of screening and providing screening tools, it's all very similar and consistent.
Cool. So does any of the process change if the patient's a new patient versus an established patient?
Yes. So when they're a new patient, we're of course asking them, you know, they come in all different ways. You know, if they're walking in, sometimes they call. There's, you know, because we provide so many different levels of service, they're really coming in different paths. But of course, we first ask them if they're able to, you know, are you able to have a telephone visit versus an in-person? Because we do have clients that need to come in for lots of reasons. And so that first gets established. And then when they have that set up, then if it's a telephone visit, for example, they'll be given an appointment. And typically the therapist or the provider or someone on that care team will call them before that first appointment and talk to them about, are you able to do a video visit? This is what it would look like. We would text you a link, and then you would, you know, you'd have to have a camera and that sort of thing and kind of walk through the like technological logistics of it. Or the clinician may, the first session, just have it be a telephone visit and just sort of say, this is a big change already, and so let's walk through the consents and let's talk through, because some of it, as I mentioned earlier, it takes some negotiating about what this could look like, and we have clients that are like, yeah, you know, have lots of, you know, experience with technology, and we have clients that are like, what do you mean you're going to text me? What is that? Where does that come up? So on my phone. So it's, you know, yes, exactly. So there's just a wide range of experience and expertise in that, and so we've been training clinicians really on being able to be experts in this, to be able to be confidently explaining it to clients, because they're kind of like IT now. You know, they have to walk them through, and they're walking their clients through all their technological issues and things like that, and if they're on a video call and the internet is not going well, they just really would stop and turn to telephone. And so the experience that our clinicians are sharing is that if the internet's not working well, it's not going to be resolved within 30 seconds, so we're just going to switch to telephone. And so they're trying to orient clients too on that, like that if it, you know, if everyone's freezing and delaying, I'm just going to call you and then we'll continue the session that way.
Yeah, that's a really good tip that I don't think we think about often, is we always just kind of hope that the internet's going to fix itself. If it's not working, just stop it and start again. Good
Right.
point.
And so part of that is walking through the client. We're like, if this happens, what happens? Or what happens if someone walks in the house that you didn't know was going to be there? Or what happens if, so we're talking through some of that, and that's part of kind of safety planning too, and, in terms of confidentiality and keeping them, their services protected.
Yeah, cool. I think that's it for me. I'm just curious to know if there's anything else that you'd want your colleagues to know about this transition, any other words of advice or wisdom that you'd like to share?
Yeah, I just want to share and appreciate that our therapists are having in terms of like headaches, like physical aches, sitting at a computer and staring, like really intently staring at a screen because you're trying to pick up on all the nonverbal cues, and with children you're really trying to figure out what's going on. And so we've been really pushing and supporting self-care, and we've been hosting this Self-Care Tuesday where we have a half an hour during the lunch hour, and we're doing a virtual meetup and have a rotating facilitator doing everything from sort of chair yoga to mindful meditation, and just any way that we can help our employees feel cared for, because it's a significant transition for people, and they're doing amazing and so adaptable, and it's hard some days. So
oh, that's so interesting. I love that, keeping that connection, maybe even augmenting the connection in this new environment, to try to build the community. I think that's really cool. Thanks for sharing. Well, we really appreciate your time, Sarah. Thank you so much for taking the time to answer our questions. I'm sure folks know how to get a hold of you, but I'll go ahead and put your email address on the screen. Sure. If you don't mind. And I'll just remind everybody that if you do have any questions, CPCA's Connected Communities platform is a really great way to keep the conversation going with your colleagues. Ask any of those burning questions that you may have. And again, just want to share my gratitude and appreciation for all of California's community health centers. You all are doing amazing work helping our patients who need it the most, and you just have my deepest respect and gratitude. So thank you so much. Take care, Sarah. Tell everyone at CommuniCare we say hi, and we'll talk to you soon.
Bye.
Bye.